A quick announcement before we move to our next speaker is that we do not have any more breaks between our presentations before the end of the day. However, people may be interested. We have some snacks available out there, and you are certainly welcome to take them on your way home. We have some food, sandwiches and whatnot from one of our from a trainee event we had. If anyone would like, you are more than welcome on this conference on eating issues to consider your nutritional needs as you leave our conference. I also wanted to mention that there were a few questions that came in during the day that I intentionally saved for the panel discussion, so I will still intend to get to some of those because it seemed there were things that all of our speakers might want to comment on. Our final speaker of the day is Dr. Lucene Wisniewski, who is also a leading expert on the application of dialectical behavior therapy to borderline personality disorder and eating disorders. Like our previous speakers, she is very actively involved with research. One thing which, in my mind, distinguishes her a bit is that she's also a clinical director and a co-founder of the Cleveland Center for Eating Disorders, where she applies these methods in a very much a real-world setting. It's always very fascinating for me to hear of her work because it's not just restricted to the studies themselves, but also a lot of that kind of in the trenches when that's where I spend my time. So I very much relate to this. Please help me welcome Dr. Lucene Wisniewski, our final speaker.
Good afternoon. I'm glad to see some people stayed and didn't leave for the snacks. Thanks for that introduction, Seth. I feel like my job at this point is both going to be easy because half of my slides have already been covered by the previous presenters, and difficult because I'd like to try and give you a sense, as Seth stated, of what it's like to try and do this work in a non-academic center. I'm curious about who here considers themselves a personality disorder expert. All right, not expert, but that's what you're here because that's really what your background is. And who here considers themselves an eating disorder therapist? And who here is just because they're interested or need CEUs? Okay. I'm actually an eating disorder therapist by training. I was trained academically using empirically founded treatments for eating disorders. I was trained by Chris Fairburn, as shown in those photos earlier today. But then I learned DBT later on in my training and really was asked, I was put to the task in a non-academic center to put together a treatment for a tertiary care facility for people who basically had failed other treatments. And so I really took both of my worlds, my DBT world and my empirically founded eating disorder world, and tried to make them fit. And so what I'm going to try to describe to you today is if you're an eating disorder therapist thinking that you want to work with the very difficult to treat, in particular our eating disorder patients whose eating disorder is so severe it becomes life-threatening, I want to give you some things that you need to think about. I may, in fact, raise more questions than I answer today, so I apologize in advance, but hopefully I'll send you home with some things to think about. And then if you are a DBT-trained therapist or a personality disorder therapist who is interested in treating eating disorders, I want you to leave with some areas of understanding of what you need to consider if you're going to sit in the room with someone who suffers from an eating disorder as well. One of the things I want to clarify, because my sense from the questions that came for Eunice, there may be some confusion about, is when we're talking about DBT, we may be even as I start this talk, be talking about several different things. The research studies that, not that Eunice presented, but the ones that are the Christy Telch, Deborah Safer research studies that are also the studies that book that you could find out in the hallway are based on, is not, if I get this right, Eunice, is not really the model that you're using in your treatment outcome studies, right? It's a very different model. That model of DBT, who here, by the way, does not know DBT? That makes my life very easy. I very apologize for the two people that raised their hands, but I'm going to keep it for the general audience. The DBT model that's used in those research studies is an adapted model that, as one of those questions alluded to, does not actually provide the full model of DBT. It's a fabulous treatment model. It looks like there's some preliminary research to suggest that it's effective, but it's probably not for the patients that you're here to find out about, the multi-diagnostic, difficult to treat, potentially medically unstable patients. The model that Eunice was describing and showed you her data on are more from a full DBT model, which is the model that I will be presenting as well. So I want to be really clear about that from the start. So when the question was, why don't you teach IE skills, that's not what we're talking about. All right. So I think part of the first question is, and again, this is really made easy for me because you've had so many really smart and competent people talking about this before I even stepped up here, is that there are empirically founded treatments for eating disorder patients, and there are these treatments that already work. Why would we even consider a new one? And how do you decide? Because again, this is my goal in life, is I want to stay on, and I hope that this becomes a goal for those of you who are in the audience who are clinicians as well, that you stay on top of your literature, that you stay on top of what we know has been shown to be effective, and then you try to figure out how to make that work in your real life situation. So if we have these empirically founded treatments, why should you start even thinking about, or when should you start thinking about using a different model? So I'm going to suggest, and this is the way that we do it in our center, is that number one, you actually try the ones that have been empirically founded first. And just by definition, if a patient comes into my center who has borderline personality disorder, I don't necessarily decide that they need something bigger to start out. We might try an empirically founded CBT treatment for them first, and if that fails, and one of the things that we know from research is that if people are going to succeed, you pretty much know it in the first 4 to 6 weeks of treatment. You don't have to wait the full 20 weeks to say this is a treatment failure. You can have a sense about that fairly early on in treatment to know whether or not you need more and if this treatment is going to work. So clients for whom traditional eating disorder treatment has failed them, and note that language because I said that importantly from a DBT perspective. They didn't fail the treatment. You don't tell someone who got penicillin that didn't get better that they failed the penicillin. The penicillin failed them and they need a different medication. So the first one would be clients for whom traditional eating disorder treatment has failed them. The second is clients who present with significant emotional dysregulation may be a case where you would want to consider DBT in your very early on intervention, and then also clients with a comorbid BPD. However, that being said, as I said earlier, we want to try, and in psychological treatment, as in medical treatment, we really want to start with what we know works first, and don't move on to adding more treatment until we're sure that that treatment is not going to be effective. As Seth said, I am working in the trenches. I'm in a non-academic environment, although I do have an academic appointment. And also, as Eunice said, because I feel like this is all we basically keep referring to each other as the earlier presentations. Even if you are a clinician and you don't have support, you can collect information on whether or not what you're doing is effective. We put out about a study a year. It's not huge amounts of data, but we need to know that what we're doing is working. This slide is merely to show you that the treatment model that I'm going to be describing to you, we're in a stage 1 situation where we are still trying to understand whether this treatment is going to be working, but that we can collect data and we can even get it published. So what does this treatment look like? And again, you've heard a lot of data at this point. And I want to talk more about specifically clinically. So you're sitting with these people, and these people, meaning patients who have eating disorders, who may also have a borderline personality disorder diagnosis, and who have an eating disorder that may be significant enough that they are medically unstable. For those of you who don't treat eating disorders all day long, I do a lot of training, both in my day-to-day life, but also as a trainer nationally for people who don't know eating disorders. And I will often hear therapists tell me, well, there must be some underlying issue. It's not really about the food. What's the underlying issue? And I think that one of the things that you have to really be aware of if you're going to sit with these patients, it is about the food, and you have to talk about it. And what I mean by that is not at all to suggest that there aren't underlying issues involved. I'll give you an example of a patient that I have that fits. You know, there are several descriptors that you heard personality types of. This is a patient who is extraordinarily perfectionistic, extraordinarily emotionally restricted, is of a low body weight. She does not self-harm, but she has lots of suicidal ideation, and she feels that her eating disorder is about control, which I feel my patients know themselves best, and I believe completely that that's an important factor that goes into her eating disorder, and that it's not really about the food. That being said, we sat for several weeks with a granola bar on the table between the two of us. It's not a table, it's an end table that sat between the two of us, where I asked her to merely pick it up and open it, and she couldn't do it. And from an in vivo exposure perspective, helping my patient to be able to, although and I firmly believe that it's not about the food, that there are other issues involved, but the terror that this woman experienced to be able to think about merely opening the package of the granola bar was enough to take your breath away. So although I'd like to say that it's not about the food, it is about the food, and you have to talk about it. There was a question that came up for Eunice about a diary card and how you manage that. And I did not bring our example of a diary card, but one of the ways in which adapting, and I use the term adapting loosely because I don't feel like we really changed DBT as Linehan wrote it significantly or at all. But if we want to use it to treat patients with eating disorders, you can't really treat an eating disorder unless you're talking about food, how much they ate, when they ate, what they ate, if they ate it, did they do anything about it afterwards, and there needs to be a way to track that. And remember, if you pick up the Marshall Linehan's original work, it's called Cognitive Behavioral Therapy for Borderline Personality Disorder for a reason. And so from a cognitive behavioral perspective, you need to track the behavior. And your standard DBT diary card doesn't do that, so it needs to be adapted. We've adapted the diary card for use in our center, and I feel like the copy of that is in our chapter, in our Adaptations chapter. So I think that book is out there as well. There's the Adaptations for DBT, the Kerner and Demeff book that Eunice and I and Deborah Safer wrote the eating disorder chapter for, and there are examples of diary cards in that book. So if people are feeling that they want to be able to use this treatment, that's the place to look to get an example of a diary card. And if you can't find it there, I'd be happy to find me afterwards, and I'll help you figure out how to get one. Okay, so again, Heather Thompson-Brenner did a fabulous job of doing my slides without me knowing. And so I'm just going to highlight a couple of points on these, which is if you are a DBT therapist or a personality disorder therapist and you want to treat eating disorders, there actually are quite a bit of data that you need to be aware of before you try to do this, or you can really undo yourself. And I'll give you a couple examples of what that means. But there are some standard components of CBT for eating disorders that are not incompatible with DBT. It's just that DBT doesn't include addressing the eating disorder behaviors, but these are standard CBT for eating disorder a la Fairburn components, such as monitoring weekly weights. As Heather really aptly pointed out, it is the one monitoring of weights for a therapist who is not an eating disorder therapist or who is training to be an eating disorder therapist can become an issue. I can't tell you how many times I've had a trainee or even a new therapist on our staff say, do I really have to weigh them? It's so humiliating, right? For who? Where is the issue? It's really just a piece of data, and you cannot treat a patient with eating disorders unless you have that part of the information. Is what they're doing making their weight go up drastically? Is what they're doing making their weight go down drastically? And unless you have that information, you can't do it. Many of our therapists do have quite a bit of reaction, and I think it's partly because of the weight bias that we have in our culture and the notion that this should be such a private matter that you don't talk about. And I think that as a culture, we need to look at that, but in the meantime, as a therapist, you need to do it. So some of these things Heather already talked about, but I think the other piece that I want you to understand is there's a lot of misinformation out there in the popular media. If you stand online in the grocery store and you pick up a magazine, you're going to find the latest diet fad, the latest piece of information where they've taken some piece of scientific data and floated it in a way to make it sexy and interesting for popular culture, and then people have lots of information that's just not true. If you don't know the facts yourself, you're going to be sitting across from a patient with an eating disorder, and then things are going to get a little ugly. I'll give you an example. I do a lot of consultation of DBT therapists who want to learn how to treat eating disorders. I was listening to a tape of someone that I had been training up for several months, who, part of what I'll get to is really understanding your own relationship with food and eating and how that might then come out as part of your therapy if you're not careful. Okay, she's talking to her patient who has anorexia nervosa, and her patient is attempting to follow a meal plan. In this situation, the patient is talking about how she had eaten, she had eaten like a pretzel for lunch or something, and then she was very hungry afterwards. And the therapist, who really felt like she was doing what she thought was an effective intervention, was trying to give the patient information about how she should really stay away from carbs, because if you eat carbs will help you gain weight and won't keep you satisfied, and you really need to eat more protein and stay away from the carbs. Now, understandably so, this is something that's and this is several years ago at this point when this happened, really at the height of the whole Atkins craze. This therapist herself was on the Atkins diet, and I hadn't realized it, which, look, I make no judgment. If it's effective, fine. But for an eating disorder patient, what you don't understand, if you haven't lived in the eating disorder world, is your patient will then take that information and not use it as a guideline, but it is now the rule book of life. And so what you're trying to do is to give her a guideline about how to perhaps eat more effectively. She now feels like if she eats a carb, she's screwed. And part of what happened then for this patient is she went on to binge and purge because now she heard that eating those carbs were bad. And that therapist really, it was a very benign comment on her part. So you really do need to understand the whole area that probably you feel like you know because you live in this world. You feel like you know because we all have our own relationships with food and eating. We don't all have our relationships with cutting. We don't all have our relationships with depressed mood. But we all have a relationship with food. And it makes us falsely believe, I think, that we all have some level of expertise that may not be there. Okay, so these are all the things that Heather talked about. I will also tell you that in the chapter that we wrote, in the Adaptations chapter, if you come from the personality disorder or DBT world and you are interested to know what you need to know, we really do outline it in that chapter. And I'm not going to go through it sort of in excruciating detail here. But these are some of the topics that you need to be aware of. Physical and psychological effects of restrictive eating, binging, purging, and low weight status. Like, how many calories do you really lose if you purge? This has been actually an ongoing debate on the Academy for Eating Disorder listserv recently, in fact. But, you probably don't know. How many calories do you need to eat to gain a pound? What do you have to do to lose a pound? How does that really work? If you are going to work with your patients, not because you're going to be prescribing that information, but because you need to know the facts, because your patients will bring you those pieces of information. Properties of specific foods and components of a balanced diet. Determinants of appetite and energy expenditure. How does metabolism work? What does it mean for your metabolism to slow down? Why am I gaining weight when I'm only eating 500 calories? How does that work? Genetic influences on body weight, fat distribution, and metabolism. How much can I actually change myself? How much is it determined by the fact that my parents were a certain size? What is a reasonable goal for me to have? All of those things you're going to need to be able to understand to effectively work with your patient. Exercise physiology and mythology, complex correlations between weight, shape, diet, and a variety of health risks. Is it really that bad to be a little overweight? Not really. But again, depending on who you're listening to. There's this whole push right now with Michelle Obama and the Childhood Obesity Initiative, which I have a lot of respect for, but my son came home the other day and he said to me, Mom, we had this thing, he's in 5th grade, we had this thing at school today and I'm pretty convinced they're going to tell us the only thing we can eat soon is apples. I said, you might be right. Recent trends or fads in exercise and diet, and as that example I just gave you, how this information impacts our patients. And then understanding your own relationship with food in your body. Again, if you don't live in this world, my research collaborator is a faculty member at a local college, and she has been coming to our center 1 day a week to see patients. And she is not someone who either has eating disorder experience nor has she ever had an eating disorder. And the amount of things that she does wrong is just stunning. And we'll have an ongoing conversation. She's like, I screwed it up again, didn't I? Just in terms of understanding how her own relationship with food and eating, her own relationship with her own body, how she wears her clothes, how she then impacts and discusses things with clients. There was that conversation earlier about the body size and shape of a therapist. I don't believe that there's any body size or shape that makes it not right for you to work with an eating disorder patient, but you need to be aware of what you're walking into when it happens and be willing to have the conversation. Every time I've had 3 kids, every time I've gotten pregnant and my body changed, there was a period of time with which I know my patients were checking me out. Now, okay, but you have to be okay and be able to have those conversations to some degree if it becomes relevant for your patient. And so knowing where you stand on it is important. I'm not saying that you need to self-disclose. And I also don't believe that people who've had eating disorders can't be effective therapists. I think it's all empirical. You're an effective therapist or you're not. And can you maintain your own boundaries or not? I think it's a person-by-person issue, but you need to do your own work yourself. So, okay, what does the treatment look at? And what are you trying to address? Again, we're trying to be clinical here and try to make it more practical in terms of what you're going to be focusing on in sessions if you're not someone who's treated eating disorders in the past. First of all, our patients are following some sort of meal plan, some sort of structured eating, including time and place in the beginning. Your meals are prescribed. They're medicine. You have an illness that is related to the fact that you have inadequate, and that can mean one end of the continuum or the other. You have inadequate nutritional intake. You need structured eating in the beginning, and you need a clock to tell you what time to eat. Because for most of our patients, the notion of hunger and fullness is long gone because they've not been paying attention to it for a long time. Balanced nutrition, meaning eating from all the food groups. And just as my public service announcement, someone with an eating disorder, taking an entire category of food out of their diet is a very risky thing. I understand that there are many people who feel that works for them in their lives, and God bless. But for patients who have an eating disorder who are prone to more black and white thinking, you take an entire food group out of their diet, and then one day they go off it, they've decided that it's all for naught, and things go to hell in a handbasket. So it needs to be balanced nutrition from all the food groups. Non-judgmental approach toward food and body, which is very hard to do in our culture, where there's good food, bad food, and my son who wants to only eat apples. And then an awareness of hunger and fullness as treatment goes on. We're going to be decreasing unstructured eating, restrictive eating, food avoidance, obsessing with food and body, which includes body checking, decreasing compensatory behaviors, laxative diuretics, diet pills, enemas, compulsive exercise, and the like, and judgments about weight, shape, and appearance. Now, So if you want to use the DBT language, I see this as nothing more than taking what is standard CBT and wrapping a sort of DBT language around it. We're talking about non-dialectical eating, which is eating controlled by emotions or urges, an imbalance in thoughts, actions, and emotions, and unstructured or chaotic eating. That's non-dialectical eating. The synthesis, or the following of the middle path, is, again, this is just putting DBT language around what would be standard CBT, effective eating. It's not good eating, it's effective. It's what works. And we talk about eating when hungry, stopping when full, and using a variety of food groups, variety of foods from each food group. Okay, this is not rocket science. I feel like this is one of those things where it takes a minute to learn and a lifetime to master. Many of us who haven't had eating disorders, this is still pretty hard, but this is the basic framework. Okay, it's just the overall for you to have an understanding of. Now, that being said, my job today is to explain to you what happens in the trenches when you are working with a multi-diagnostic patient who may have multiple axis 1 disorders. Their eating disorder may be significant enough that it requires medical attention and may be intermittently life-threatening. They will likely have an axis 2 disorder, as well as other problems. And so when there's so much to work on, how do you prioritize? How do you think? I keep thinking about what Carlos said this morning about keeping it simple, and I'm hoping, Carlos, that after my presentation you can give me some brilliant ideas when you hear about my patients about how to keep it simple, because I haven't figured it out yet. And so the first gauge, Eunice had started to talk about targets, and this is where I've had the experience where I think, thank God for Marsha Linehan, because I sit in my session with a patient and I think, oh my God, where am I going to start? And I don't mean that judgmentally, I mean that from sort of an overwhelmed therapist point of view. When there are all these multiple pieces, how do I even start to think about it in a way that's going to be effective, that keeps me on track and keeps you getting better? So the first is targets. Again, Eunice alluded to these, but I would like to talk about them in a little bit more depth. So again, when you're sitting across from your patient, you can start to think about, how do I do this? So from a DBT perspective, target 1 is anything that's life-threatening, which obviously we all know to mean suicide and parasuicide. This is actually, what I'm going to say next is slightly controversial. Controversial only in the sense that I think as a field, and as a field, there really aren't many of us, but still, people who are trying to incorporate the DBT framework into their work with eating disorder patients, you can get several different opinions on. So I'm going to give you my opinion, and if during the question and answer period you have a different opinion, I'd love to hear it. I think that eating disorder behaviors can be included in target 1 when they're life-threatening. Now, this actually becomes a little bit more complicated, but let me talk about what that means. Again, if you don't work with eating disorder patients, you need to understand that there are certain conditions that can make someone imminently at risk for death. Okay? I've listed them for you, actually, on this slide, which is a summary of what we had written in that chapter that I keep alluding to. Is somewhat amended because we're still, and that chapter's like 3 years old at this point. We're still sort of evolving in our thinking about how to manage eating disorder behaviors that are life-threatening. So the first is bradycardia. So if someone has a pathologically low heart rate, they may actually need hospitalization to remedy that. And this is the other thing that I want you to be aware of. We've been talking about outpatient care. Our patients who have severe eating disorders sometimes need to be hospitalized to save their lives. Bradycardia may be one of those cases, but depending on and working with a physician, which is why if you treat eating disorder patients, you need a multidisciplinary treatment team, and a physician needs to be on your team. But so bradycardia is one of them. So if someone is bradycardic, which is usually the result of severe malnutrition, their eating disorder behaviors become target 1, because this is how people, there's 2 ways that someone with an eating disorder dies. One is suicide, and the other one is usually cardiac. Bradycardia is one of the things that makes you at risk for a cardiac event. So continued restriction, both fluid and food, can result in cardiac death. So in my head, that means that's a target 1 behavior. An arrhythmia, which is in medical language, usually described as a long QTC, which is describing a heart interval. And if it gets elongated, it also puts you at risk for a cardiac event. If someone does that and continues to exercise or continues to restrict, that is target 1. We don't know. The problem, I'd say, in the eating disorder field, it's really the medical field. And I don't think this is nobody's fault, except that I just don't know that our understanding medically is that fine-tuned. We don't know exactly at what number that means that it's like pulling the trigger. We don't know at what level heart rate. We certainly know at the very low end of the continuum, but once you've sort of passed a threshold, you're kind of in no man's land. But we know that further behaviors are only going to make the matter worse, but we don't know where the line is. So it makes it a little bit, and this is where, from a DBT perspective, I know that when we were writing this chapter, we went round and round with Marcia some about whether or not these things were actually imminent enough to be called target 1. So this is, I think, part of where the questions come. But arrhythmia is the second one. Electrolyte abnormalities is the third. So if someone purges, thank you, if someone purges or takes laxatives in a very great degree, it could set their either the potassium, phosphorus, or magnesium into pathological levels, and continuation of those behaviors can result in death. Finally, chronic Ipecac abuse. That's how Karen Carpenter died, was by abusing Ipecac. You can't really, things have changed in the recent years where you're no longer given a bottle of Ipecac when you go home with your new baby, because every home needs one. But that it still is available to some degree. So those are things that would be imminently life-threatening and be target 1. I'll tell you, one of the things that makes where this also raises another question is there are times when our patients use these behaviors not intending to die, knowing that they're medically unstable. And there are times when they use these behaviors hoping they will die, and whether or not they should be addressed differently. Okay, I'm going to plant that question, and we're going to talk about some cases and see if I'll be curious to see what you guys think. Target 2 is anything that gets in the way of therapy. And those were already reviewed by Eunice in her talk. But I thought we should talk a little bit about, again, if you don't live in this world, these are behaviors that may either be new to you or you might not even be aware that they're going to be therapy-interfering behaviors when you sit with our patients. I went through, what I did was when I was preparing for this talk, I just went back to Marcia's book, pulled out her sections on therapy-interfering behaviors, and listed for you a couple of what are considered the standard therapy-interfering behaviors, and then highlighted the ones that I think are pertinent for our patients with eating disorders that come up when you treat these complicated folks. So first are non-attentive behaviors. Standard ones are canceling appointments and dropout. You don't need to know that's therapy-interfering, right? That's like, obviously. If you're not showing up, you're not getting the treatment. Getting admitted to the hospital, therapy interfering because you're not coming in to see your therapist. You're in the hospital. But one of the things that happens with our very difficult patients is inadequate intake, resulting in the inability to be attentive during sessions. I had a patient that I was seeing at 4 o'clock in the afternoon, and actually her appointment time had changed. I had been seeing her in the morning. It took me a little while to catch on that something qualitatively had changed in her status, like her mental status and her ability to remember homework and do what she was meant to do during the interim in between each sessions, and come to find out that, and this was sort of early on in our treatment, that she ate breakfast and then didn't eat anything again until 8 o'clock at night, and she had a very minimal breakfast, and I had been seeing her right after breakfast initially, and she was clearly more with it then. But if you can't remember what's going on from session to session because you don't have enough calories in your brain, then that's therapy interfering. Actually, it's way more than that, but it's also therapy interfering. So this patient agreed to come early, to either change her appointment or come early and eat something before our appointment so that she could be more cognitively present during therapy. Now remember, these are. I'm not suggesting that this is a good standard way to treat your eating disorder patient. If she's that malnourished, right, you have to wonder if she's in the right level of care. We haven't even talked about level of care, but there is more than just individual therapy. There's intensive outpatient treatments, day treatment, inpatient, Partial hospital, there's lots of other options. I'm talking about people that have failed multiple other treatments, and we're trying to do this treatment as an outpatient in this minute. And I'm sorry if that's confusing, but I think it is in general to know when someone needs to be in higher level of care and when they're not. Non-collaborative behaviors. In standard DBT, we're talking about inability or refusal to work in therapy, lying, and for eating disorder patients, there's manipulating weight. If weight is an issue and you're expected to be on a weight-gaining trend, many of our patients will do things like water load, drink a lot of water before getting weighed, hide things in their clothing to make it appear that they weigh more than they actually do. We don't throw them out of treatment for this. We identify it as therapy interfering and we address it accordingly. The other is refusal to work on eating in vivo. One of the standard eating disorder interventions is eating live, eating with your therapist. And certainly most treatment programs involve, standard therapeutic meals. If your patient, I have a patient that I was working with recently who was extremely emotionally avoidant. Would go home, we would have a goal that involved her eating, she wouldn't be able to do it, her behavior chains were filled with lots of empty circles because she's so emotionally avoidant it's hard for her to even know what's happening for herself. So I said, okay, great, bring the food into session. Her unwillingness to do that became therapy interfering. I don't fire her right away. We almost got there. She eventually brought the food in. But that we identify it as getting in the way of therapy. You say that you would like to work on your eating disorder. This is one of the barriers. One of the ways we can get around that barrier is by you bringing food into session, but you don't want to do it. How are we going to solve this problem? So it's a non-judgmental approach to the fact that her behavior is getting in the way of therapy. Non-compliant behaviors, not completing diary cards or homework are standard. And in our treatment program, which we provide intensive outpatient and day treatment, patients are required to bring their own food to treatment as practice, both for preparing, putting together, and then eating foods. And so if you don't bring in all the food that you're supposed to need for a therapeutic meal, it's therapy interfering. Again, in some programs, you'd get kicked out for that. They'd say, we can't treat you if you're not willing to do the bare minimum. We see it as therapy interfering, and we address it as such. Actually, I had a patient the other day who was coming in to see me. She texted me, she said, I'm going to be 5 minutes late. So she comes and she says, okay, this is my behavior chain. I restricted all day. I knew I was coming to see you. I knew that somehow you were going to figure out that I hadn't eaten lunch, and then you were going to go to the kitchen and get something that I needed to eat that I didn't want to. And so I figured I should stop and get my lunch before I came in, and that's why I was 5 minutes late. I said, works for me. Because I usually go get them the cheese crackers that they would rather die than eat. Pushing the therapist's personal limits, phoning too much, standard DBT therapy interfering behavior, and then continuing to lose weight and refusing to collaborate on weight maintenance or gain is therapy interfering and burns out therapists. I have a patient that this happened with just recently, where we were really trying hard to work on her. She'd been in multiple treatment programs, and we were working on her taking personal responsibility. Her family was going to try and actually get medical guardianship for her if she wasn't able to pull this off. And her weight was dropping, and she was refusing to collaborate on finding a way to change that status. And part of what I think really turned it around was me saying to her, look, if you continue to lose weight, it's burning me out. Like, if we could at least find some place that you can stand still, let's stand there and breathe for a minute. But you got to stop losing, because losing means we're not going to get to work together because your parents are going to mandate you and you're going to have to go away. And I think that was one of the ways in which using the therapeutic relationship in that way, again, non-judgmentally, was a way that she was able to take some ownership and stop the weight gain. Now, I don't want you to think that I'm some sort of miracle worker, because it's not like she's gained an amazing amount of weight since then, but we did stop the weight loss. Behaviors that push the organization's limits, not waiting for the therapist in the waiting room is the one standardly described in Marcia's book. but vomiting in the lobby restroom, okay? Again, if you don't work with our patients, these are not things that might cross your mind. We have an office that's in an office building. We have our own bathrooms are locked on our unit, or it's not a locked unit, but the bathrooms are locked. You don't have access to it, but there's a lobby bathroom. And one of our patients was throwing up in the bathroom downstairs. She'd come upstairs for treatment, and then she'd leave and go throw up before she left. And so once that was identified and someone fingered her, one of the maintenance guys saw her coming out of the bathroom. And so we addressed it, and I addressed it with her, not punitively, not judgmentally, not humiliatingly, but I told her, I said, look, if you continue this behavior, it's quite possible that we're going to get thrown out of the building, and then I'm not going to be able to treat you anymore because I'm going to be doing therapy on the street. So we need to figure out how you're going to at least be effective enough to get out of my building before you throw up. I understand that may seem irreverent, but the truth of the matter is this is a patient who had been through 4 other residential treatments, and while she was in treatment was having behaviors on the units that she was being treated at. This was a big step for this woman. But again, that was going to push the limits, that me getting thrown out of my building was where I was drawing the line, and I was going to fire her before I was going to get thrown out of my building, and she stopped the behavior. Behaviors that decrease the therapist's motivation, slow progress is one of them, but lying about intake is another. Part of what happens with patients, especially patients of low body weight, I will often say that our patients, eating disorder patients, I'm not talking now about patients that also carry a BPD diagnosis. In fact, I think we're going to do some research about this in the next 6 months or so. But eating disorder patients are usually omitters. They're not liars. They're more willing to tell, my classic example is one of my patients now actually has what I call a user's manual. She goes into skills group, she has a new skills group leader, and she says, here, listen, this is all the things you need to know about me. One of them is I will not tell you the whole story. Like my mother said, did you have lunch? And she said, we ordered pizza, which is true. She didn't eat the pizza, but she ordered the pizza. So our patients are omitters. It is our experience, and this is what we're going to do some research on in the next 6 months, that our patients who carry a more primary BPD diagnosis are more likely to lie. And I mean that non-judgmentally. That is my running hypothesis. I'll let you know maybe if I ever come back about whether we find that out. But that our eating disorder patients usually just omit. But part of what ends up happening is if you are asking someone to be on a weight-gaining trend and they're doing a diary card, and our diary cards do require them to write down their intake, and they're not gaining weight, you have to wonder what's happening. And that's the sort of thing that burns your therapist out, because I'm racking my brain trying to figure out what else is happening. And if you just tell me the God's honest truth, it'd be easier to move forward. 10 minutes. Okay. All right. So we talked about therapy interfering behaviors. This is just a summary slide. And then we have the quality of life interfering behaviors, which are standard. So I want to talk a little bit about a couple cases to see if it can help us all try to conceptualize what is happening, because it's really real, at least for me, maybe my brain is too small, it's really complicated. There's a 25-year-old woman with a 10-year eating disorder history. I alluded to her earlier. Multiple treatment attempts is the one who, she's low-weight anorexia nervosa, purging type. She would purge while on these units. She would usually be able to gain weight while she was there. The minute she was out, she would drop like a stone, return to her behaviors, very, very actively passive. She meets criteria for personality disorder, NOS. Her self-harm is scratching and biting herself. She has intermittent suicidality without intent or plan, severe PTSD from a recent event, and possibly some past history, but I'm not exactly sure because she's very emotionally avoidant. She has hypothyroidism, which results in severe depression when she doesn't take her medication. Okay, where are you going to start? Oh, did I say that she's intermittently hypokalemic? It's not on this slide. Okay, so she purges, oh, by the way, she gets hospitalized once every 4 to 6 weeks because her potassium drops too low. So where do you start? So obviously, target one for her is purging when hypokalemic, because that's the thing she's going to die from first. Her suicidality without intent or plan, to me, that's a question mark. And again, I'd love to have this discussion. What about her scratching? You know, if you go to the book, the Bible, if you go to Marcia's book, all episodes of self-harm need to be addressed, right? It's parasuicide. But she's never really scratched enough that requires medical attention. How do you think about it in this context? Her target 2 is she's low body weight, which actually is one of the things that we've been able to track, makes her more likely to become hypokalemic. When she's purging as much as she purges between 3 and 7 times a day. And she's not in an inpatient level of care because she's been there 4 times before. So low body weight, not following her meal plan is therapy interfering, not taking potassium when hypokalemic. She has a protocol that she's supposed to follow. She doesn't follow it. That's therapy interfering. Unable to address some post-traumatic stress disorder symptoms that she has that are directly related to purging. When she does her behavior change, she leaves those blank. I'm not suggesting we need to work on her PTSD, but I do need to understand what's in that bubble so that I could actively help her deal with those feelings so that it doesn't lead to purging. And then she was recently asked to leave her graduate program in pastoral counseling. So she shows up for your session, and she's really upset because she just got kicked out of her program, but she's hypokalemic, scratched herself, and her weight is down 3 pounds. Where do you start? Case number 2, 38-year-old woman, 15-year history of an eating disorder, multiple treatment attempts. She meets for EDNOS. She really has anorexia nervosa, but her body weight's not low enough, which, by the way, is the most invalidating. If you see somebody with basically an anorexia nervosa who doesn't have a low enough body weight to meet criteria for AN, and who has a personality disorder, this is often a very difficult place to be. They find it supremely invalidating. No one can tell how sick they are. They're constantly struggling to get there because they don't feel like they've fully arrived in their eating disorder unless, and I'm sorry, I don't mean that to sound judgmental because I don't really mean it that way, but this is the coup de grace for them, and they're never going to reach it because of their biology. So she's EDNOS, significant restriction, she's normal body weight, she purges, she uses laxatives, diuretics, diet pills, and she exercises. She meets full criteria for BPD, multiple lethal suicide attempts. She has a very strong history of childhood sexual abuse that was perpetrated by a physician, which makes the whole getting weighed in a gown very complicated. She has major depressive disorder and diabetes mellitus. Okay, so her target 1 clearly is her suicide and her self-harm. That being said, she periodically has a long QTC interval, and she exercises while she has chest pain. Is that target 1? Okay, I mean, this is sometimes she exercises on purpose when she has chest pain as a suicide as a way to hoping that she's going to die, and sometimes she just does it because she's so eating disordered she can't stop herself. Is there a difference? I'm not going to do the third case just because I want to talk to you about, I want to say 2 real important things. So the function and context of an eating disorder behavior will determine in which target it falls. So if you're restricting prior to a therapy session and you're bradycardic, it's target 1. If you're restricting prior to a therapy session and you're not able to remember what's going on, but you're not medically unstable, it's target 2. This is what I'm suggesting. And if you're restricting but you're able to remember and you're not medically unstable, then it's target 3. So it's complicated. Okay, you got to stay on your toes. I want to talk about phone coaching and how it's a little bit different when you work with eating disorder patients. Eunice, something to it. She mentioned it. It's the end of the day. So 24-hour rule, you all know about the 24-hour rule in DBT. If you've harmed, you're not supposed to call your therapist within 24 hours because we don't want to reinforce that behavior, okay? This doesn't really work with eating disorder patients. We provide, not for the eating disorder part, we do use the standard 24-hour rule for self-harm behaviors, but we don't for our eating disorder behaviors. And we do, especially when the eating disorder is life-threatening, we do require that our patients call us prior to having an eating disorder behavior as a way to, in vivo, give them coaching to extinguish those behaviors and be more skillful. If you use a 24-hour rule with eating behavior, you could basically punish somebody out of calling, right? If they missed breakfast and then they can't call you for 24 hours, it's a free-for-all. So we say, instead, that we use what we call the next meal snack rule. If a client is engaged in the eating disorder behavior, they're not permitted to call for coaching until their next scheduled meal or snack. And we're not talking about that last episode, we're talking about this episode and how you get back on track. It's actually extraordinarily effective for helping people who are faced with multiple triggers and events that especially if they're in treatment, they're supposed to be eating 2 to 4 times a day. And this coaching can be invaluable. I wanted to give you an example as my last piece here, well, actually my second to last piece, of a phone coaching example that I had recently, just to give you an idea of how this goes. Patient texts me. I don't know about text. We'll have to talk about that later. Patient texts me, having a rough day. Cemetery to see mom, who died, obviously. Sorry. Like, was that obvious? Cemetery to see mom and anxiety about bridal shower this afternoon. Urges for restriction high for lunch. Can you coach? Now, this is someone who borders on abusing phone coaching. She calls me or texts me for almost everything. And we've been trying to differentiate. Do you not know what to do, or are you trying to text me for willingness because you're not sure you want to do it? So I say, sounds hard, validation, and glad you're reaching out. Are you asking for help with willingness to eat or what to eat? Like, what are you asking me? She says, willingness. Got it. How does restricting lunch get you closer or farther from being the mom or role model you want to be for your girls? She's got 2 little girls, and this is the reason why she wants to get better. This is somebody else who's had this eating disorder for 15 years. She's probably personality disorder, NOS, is medically unstable, has lots of therapy interfering behaviors. So she says, ouch, that hurts. I'm not comfortable with the food option, so that I really got her with that, because that is her goal, linking up her goals to what she wants to do. I'm not comfortable with the food options. This is at the shower. I'm willing to make up the meal plan when I get home, which is willing for her. Usually she'd just not eat at all. Love that you're willing to make it up at home. Sounds like a reasonable synthesis. Fabulous willingness, trying to reinforce the willing behavior. So then she says, okay, I had a salad. And I'm thinking, a salad? But that's not what I said. I had to check in with myself, let that go, and say, okay, look, that's a start, much less to make up later. That's nice. And she says, I'm really trying. Like, whatever I said there, it really hit her. I'm really trying, Lucene. And I say, I can tell. Okay? So this is the kind of way in which coaching around food and eating can really make a difference for folks. I have 2 slides and I'm done. All right. So look, we're not really making massive changes to a model, but what you need to, I'm just going to reiterate what Eunice said, which is if you're going to make changes to anything that's already existing, or you're adapting the treatment to be used with a new population, you need to evaluate whether or not what you're doing is effective. Now look, even if you're not changing anything and you're just seeing your patients in your office the bigger picture of making changes to research is not relevant for you, you should be tracking whether or not your patients are getting better. Okay? This is actually a graph. I graph the weights of all my low body weight patients regularly. The top graph is what we would expect them to do. The bottom line is what this patient is, an actual patient's graph, what the patient actually did. Okay, and I will. So you might expect with a low weight patient that there would be an expected weight gain per week, and you map it out, and then you show her weight in relation to it. Okay, but that's just one variable. You could be looking at mood. You could be looking at body satisfaction. You could be looking at restrictive behaviors. There's lots of other ways that you could do this. But what I want to say to you is, even if you're not a researcher, you, for the sake of yourself and the sake of your patient, you need to be tracking whether or not what you're doing is effective and not just keep doing more of the same. Thank you.
Thank you. We have questions for Dr. Wisniewski. I've got a few that have come in already. The first one right off is, What do you say to a client who has worked with Overeaters Anonymous and has accepted the model that all white food is evil, off limits? They resist all prescription from therapists that there are no evil foods, and all foods should and can be part of healthy eating.
They reject that.
They reject that.
Yeah, well, then you have to work with it, right? I mean, I don't like that model just because most of my patients, when they have that white food thing, eventually there's a time where they eat the white food. It may take 2 months, it may take 3 years, it depends, but often they violate it, and once they violate it, they go over the other side. If that's something that they feel absolutely committed to, well, then I'm going to, because again, maybe I need more narcissism. Actually, it's my partner tells me all the time is I need more narcissism. I don't believe that I know better for a patient than what they think they need for themselves. And so it's all empirical. Fine. You want to go with that model? Fine. Then let's figure out how it's working for you and how it's not working for you. And I move with it. Now, if somebody was doing something actively that I thought was life-threatening, I'm not going to go with that. But from this perspective, I'm not going to have that fight because you can't win.
Next question is, while in the trenches, how do you work the therapeutic meals with clients on food stamps who usually do not have enough money and have to choose between healthy and bulk for the family?
You know what? The argument that patients don't have enough money to eat healthily is poppycock. Okay? There's nothing cheaper than a bag of rice and some beans that you buy in a bag and cook them. Now, what problem is that most patients don't want to eat that. But that I think there are ways that people can eat healthily and eat reasonably on a budget. So I don't, when that piece gets put in front of me, I'll say, okay, fine, let's make a budget. Let's figure out exactly what you're going to buy at the grocery store. I'll help you figure it out. I don't get put off by that.
What is the role of discipline and self-restraint in the treatment of eating disorders? Not sure what the exact quote is.
I don't know what that means.
Big. It sounds like that's
Discipline
okay.
and
We'll see
self-restraint.
if that person wants to add to it and send it in. Let's have that come in.
Yeah.
Your thoughts about The Biggest Loser on TV?
Can't we save that for the panel?
Let's.
Can I tell you what I don't really watch TV, and I'll give you my absolute honest opinion because if you can't tell, I have no frontal lobe. I was laying in bed once sick, and I put it on, and they had a father and son in their underwear. And I couldn't watch it. I was moved almost to tears to think that you know, as a culture, we would take people and exploit them in that way where it's all fine for now. What happens in 15 years when they go back, and now it's on TV, and then it's on YouTube? Yeah. Sorry.
How do you feel about using a nutritionist or RD as part of the therapy process if the therapist collaborates closely with the nutritionist?
You know, I think I've worked in both models. I've worked in a model where, as the therapist, and that is the classic CBT model. You're expected to know as much as a nutritionist knows to be able to advise your patient. That being said, in our own center, we do have a nutritionist for collaboration, and I think it can work both ways. My caveat to you is that you don't then punt all of that information to the nutritionist, because you need to know as much as the nutritionist knows about what your patient is eating and how they're eating it. Because that would be my only worry about it, is that you'd step back from that.
Ever use blind weight? I think they mean weighings.
Yeah.
Yeah.
This is an interesting clinical question. In CBT, you weigh them, it's just data, it's part of the information. It's just how you're supposed to do it. I have certainly had patients for whom, so I always start out weighing people where they know their weight. I have had patients where knowing their weight has become therapy interfering, so we've made a collaborative decision to take a period of time where they don't know their weights with the full expectation that at some point they know it. Because whether or not you tell it to them, they go to the doctor, something happens and they find out, and if they are not prepared for that, it's usually worse than having known all along.
At what point in someone's treatment do you feel it is appropriate to address PTSD, traumatic events? Do they have to have some recovery under their belt?
Yeah, this is an empirical question, I think. I mean, from a DBT perspective, we've been told, with the exception of a study that just came out in the last year or so, that you really need someone to have a good degree of skills under their belt before you address PTSD symptoms. And I think that, whenever we're getting a referral from the community where PTSD has been treated, usually what ends up happening is the PTSD treatment ends up taking priority over the eating disorder treatment, and it's never clear to me that that's a good idea. I think that what the basic recommendations is that there's a bit of recovery that happens before you do that. Now, that being said, we have 2 patients in our center right now who are these chronic, long-term, multi-diagnostic, everything else hasn't worked, and we are trying, again, tracking data and being empirical about it to address their PTSD as a way to say, okay, look, we haven't done this yet. Let's see if we address their PTSD, if we are then better able to get back to their eating disorder. But in general, I think you want to do the eating disorder first.
We have another question that's come in on, we had an early one earlier in the day about an obese eating disorder counselor and how can this be okay? And the person likens it to someone receiving drug counseling from someone who's still who's using or in their own recovery.
Okay, so I'm not going to be politically correct. Just because someone's overweight does not mean they have a pathological relationship with food. Okay? So people come in all shapes and sizes for a reason. There's a normal curve for a reason. Some people's biology are just that they're bigger than others. And I think we cannot assume that just because someone's overweight, it means that they have a pathological relationship with food. And I think that this is part of where, and again, this is where I'm not being politically correct, and I'm from New Jersey, so I don't know how to not just say what I think. But I think you have to really think about where your own value judgments come if you are going to work with patients who have eating issues, because my guess is, and I mean this with all due respect, that if you are thinking that that's what that means, you've got some other misinformation or maybe some bias that you might need to work out before you sit across from a patient.
Do you notice an increase in eating disorders in populations with medically restricted diets, such as renal diet, diabetic diet, cardiac diet?
You know, I don't work with the medical population, but I could imagine a scenario in which the restrictive eating triggers a biological vulnerability. We see this all the time, right? You know, so it's not, eating disorders are an interaction between biological, psychological, and social factors. And so the restriction in and of itself can trigger an eating disorder in a vulnerable person.
Thank you. And we're going to move to David Klimanski on the balcony.
Okay. When would obesity-related medical problems be considered an imminent life-threatening target to address in therapy, such as could it ever be a primary target or number 1 target?
I don't know of an obesity issue that's imminent in that same way. Now, Mary, can you think of something that might be that same way? I mean, usually they're more chronic, just like chronic malnutrition in a patient with anorexia nervosa will eventually result in their death, but it's not as imminent or there's not a marker in the same way.
Okay. And what techniques do you use to reduce obsessing about food or body image or ruminating about what has been eaten?
You know, part of the thing that I don't think that most people really understand is malnutrition and starvation in and of itself results in obsession. So if you think about your own life, if you've missed lunch for some reason, all of a sudden you notice that you're thinking about food, it's because your brain doesn't want you to starve to death. So there's a certain amount of obsession that is really remedied by adequate intake. Once that happens, then we're talking about observing thoughts, recording thoughts, and understanding other reasons for those obsessions. But really regular eating takes care of a lot of it.
And just one last question. Does weighing patients reinforce the obsession with the number itself?
I'm sorry, say that again?
Does weighing patients at the beginning of your session, does that reinforce their obsession with the number itself rather than the actual goals that you're working toward?
You know, sometimes. I didn't do it. Sometimes that happens, but it's, again, a necessary evil, as was talked about earlier in terms of self-monitoring. You know, if it's that big a deal, probably we ought to figure it out because someone's going to tell you your weight at some point. And not knowing it, I think, is also sort of the other end of the continuum as problematic. And we see patients who run both ends of the gamut, who weigh themselves obsessively, literally 14 times a day after everything they've eaten, every time they've voided, every time they've had a bowel movement, take all their clothes off, weigh themselves, get dressed again. I mean, to that degree. And then there's patients who will avoid it at all costs. And neither one of those is normal. Yeah. You're welcome.
Thank you. Dr. Wisniewski.
Thanks.